Auzubillahi minash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. My name is Professor Shahzad Waseem from Pakistan, and I'm practicing clinical ophthalmology for the last more than 20 years, Alhamdulillah, right now. And I'm involved both in the uh, clinical work, surgeries, and teaching also. In this small video, I just want to talk about options of visual rehabilitation for the patients with cataract. What are the options? As we all know that these days the best option is phacoemulsification, and there is uh, no better option than phacoemulsification. But the aim and objective of every eye specialist is obviously, and from the patient's perspective, is the visual rehabilitation. Phacoemulsification is routinely being done in Pakistan. Before the invent of phacoemulsification, we used to do extracapsular cataract extraction, in which we had to use 5 sutures. It is a sutureless surgery, and rehabilitation is very early. And in most of the cases, the patient is 6 by 6 the very next day. Uh, in this video, I'm going to talk about manual phaco or small incision cataract surgery. It is between the two extremes, extracapsular cataract extraction and phacoemulsification. And I'm it is the a type of surgery which I will explain a little bit in this video, and in coming videos I will be talking more about this and about this technique and how to learn it. I have been practicing it for many years. Besides phaco, this technique, which is called SICS or MICS or manual phaco, small incision cataract surgery, in my humble opinion, is the best option for countries like Pakistan, India, Nepal, Somalia, or in special circumstances like the political and financial instability which we are passing through right now in Pakistan, because it is very cost effective. Uh, when we don't need a machine first of all in this surgery, and we don't need to apply a suture. At the most, one suture is applied, and we can take the cataract easily out. We can put the lens, and I have a paper published on this. The comparison between the comparison between preoperative and postoperative astigmatism after uh, this manual phaco, and the results are very promising. That is, in the areas where the people cannot afford the expenses of the phaco, because uh, phaco machine is very costly. It has tubing which is very costly, and in this as the machine is not being used, everything is done manually. It is the expertise of the surgeon which counts. And in the paper which I published, there was astigmatism of less than 1.25 between pre-op and post-op. Difference between the astigmatism was not more than minus 1.25 droplets centical, and patient on the very first day after small incision cataract surgery like phaco becomes 6 by 6. So what I want to say that because of special circumstances, lack of resources, we should not adhere to any particular technique as we become acclimatized with it or practicing it for many years, but we must have a flexible mind and flexibility in our thought process to know that what are the circumstances, what the patient can afford, what are the possible outcomes. There are many exceptions. There are some very hard cataracts in which phacoemulsification is usually not recommended. In these patients, a small incision cataract extraction or manual phaco is the best choice as compared to the extracapsular cataract extraction. And in normal, in any cataract, it is also very best. Uh, in the very best in the meaning that if the patient cannot afford phaco emulsification, so I think we should learn it. Most of the Indians are doing it, most of the Nepali doctors are doing it, some of the Pakistani doctors are also doing it. Alhamdulillah, I am doing it, and I will be teaching it also if Allah want me to take this work from me. And it is very cost effective, I'm saying it again and again. So in this video I just wanted to let you people, give you an introduction of manual phaco, that what happens that we give an incision 1.5 to 2 millimeter behind the limbus, a frown incision or a straight incision, and we make a tunnel between the cornea and sclera, and then we enter into the anterior chamber. We do capsulorhexis or we can do V capsulotomy. There is no compulsion that we make if during phacoemulsification, if there is something goes wrong with the capsulorhexis. After all, we all are humans. The hand is not stable all the time. Then we may have to convert it. But in small incision, you can go for CCC, and you can also go for V capsulotomy, and you can easily take the lens with a special technique. It is also not that easy. Every technique is not easy. It has to be learned, and bring the cataractous lens into the anterior chamber, and through visco expression we take it out of the eye. We wash the lens matter, and we usually apply one suture at 12 o'clock. And in my experience and in many other colleagues of mine which I am in contact in Pakistan and India and Nepal, the next day the patient is usually very happy with almost 6/6 vision like phaco, if the technique has correctly been executed. So in the coming videos we will discuss about how to do it. But in this video I just want to tell you that there are three techniques of cataract extraction. One is extracapsular cataract extraction, which was the latest of its type, which ruled the ophthalmology for decades after intercapsular cataract extraction. Then came the phacoemulsification, and during this period some innovative ophthalmologist, uh, perhaps from Nepal, um, discovered or invented this middle technique which we call manual phaco or small incision technique. I hope that we can meet in the next video, inshallah. If you have any questions or comments, you can post below the video, and I would be very happy to learn from you people. Thank you very much.